Good evening and namaste everyone. On behalf of Intas Pharmaceutical Limited, I Dr. Mithilesh Nayak once again welcome you all to this seventh edition in the practice pulse of hypertension. Today we are going to discuss important topic that is the orthostatic hypotension. And to guide us, we are having with us two eminent cardiologists, Dr. Ajay Mahajan sir and Dr. Kamal Sharma sir. And to moderate this session, we are having with us our course director, Dr. J.C. Mohan sir. He is the chairman and head department of cardiology at Jaipur Golden Hospital, New Delhi. So, without wasting much time, I hand over the session to Dr. J.C. Mohan sir. Over to you, sir.
Thank you, Dr. Nayak. Good evening, ladies and gentlemen. Welcome to this webinar series on practice pulse in hypertension. I am excited today to moderate this session on orthostatic hypotension, in which we have two extremely talented academic cardiologists as faculty. Professor Kamal Sharma, who comes from Ahmedabad, is well known to everybody who practices in the field of cardiology and medicine. He is an accomplished intervention cardiologist working in Sal Hospital as well as UN Mehta Institute of Cardiology and also BJ Medical College. He has more than 200 publications, some novel, absolutely brilliant ideas which have been patented, which carry his name. We are also fortunate to have Professor Ajay Mahajan from LTM Medical College, Sion, Mumbai, who also is an accomplished intervention cardiologist and a device specialist. And following Dr. Kamal Sharma's talk about orthostatic hypotension, Dr. Mahajan is going to discuss with us a case of orthostatic hypotension, the issues and challenges and management. So without wasting any of your time, let me invite Professor Kamal Sharma to start his presentation on orthostatic hypotension. What have we learned so far? Professor Sharma.
Good evening, everyone. Respected Chair, Dr. J.C. Mohan, my senior professor, Dr. Mahajan, and dear friends and colleagues. So I'm going to touch upon orthostatic hypotension as we understand today, especially when we are dealing with a subject like hypertension. It's very important to know because, as I will touch upon, the majority of the patients who develop orthostasis are actually the patients who are also having hypertension. So basically, my talk is going to be focusing upon definition, epidemiology, normal blood pressure response to standing, etiologies, which includes autonomic failure, volume depletion, medication, aging, how do we diagnose it, how to evaluate, complications of the same, treatment strategies, which we'll be talking about non-pharmacologic as well as pharmacotherapy, and most important, something about patient education. So by definition, the significant reduction in blood pressure upon standing is what is defined as orthostatic hypotension, and this includes abnormal fall of is the progressive and sustained fall in systolic blood pressure from baseline value of 20, more than 20 systolic or more than 10 diastolic, or a decrease in systolic to below 90 on change of posture. And in hypertensive subject, the cutoff is 30 in systolic, which may be more appropriate, though this is not a stamped or universally acceptable definition. But 30 is what we usually take for practice guidelines, that since blood pressure fall after standing may largely depend upon the baseline blood pressure. So classically, it's been categorized in JACC in 2018 into two types. One is the classical OH, which happens as soon as the patient stands up and happens and is finished within a couple of minutes, not reaching into double digits, usually in time, in terms of minutes. It usually finishes off in a couple of minutes, like 4 to 6 minutes, and then there is a fall in blood pressure. When you compare this with the delayed presentation, most of these will start happening beyond 10 to 12 minutes, and then the blood pressure starts falling. So there can be two types, as patients can actually come and actually tell them that they stand up and they immediately feel giddy, versus those that I am not so giddy when I'm getting up from my bed, but I do get giddy as soon as I've reached a washroom or my urinal in the middle of the night. So this initial orthostatic hypotension would usually be responding with a reflex rise in the heart rate which will not always be present in patients who present with the delayed kind of presentation of orthostasis. Epidemiologically looking, orthostatic hypotension is very common in elderly, at least in part of the baroreceptor impairment that they have accompanied with. 6% of general population overall is supposed to have this this disorder, and it increases exponentially, ranging from 10 to 30% or even 55% if you take older patients, which is anybody who's more than, say, 70 years of age. Now, autonomic impairment with orthostatic hypotension is a very common disorder which always should be worked upon by a cardiologist or a treating hypertension specialist, because significant orthostasis rarely occurs in patients with autonomic intact reflexes. Vasovagal syncope, as we often know, it may be triggered before the development of orthostatic hypotension. It ensues, and hence the two should not be confused to be present or mixed upon, and the symptomatology can be very devastatingly missed in these patients and being labeled as only vasovagal, when actually the patient is somebody with autonomic impairment with orthostatic hypotension. So chronic orthostatic hypotension, it results when the autonomic mechanisms are impaired, and it can be disabling in primary neurodegenerative disorders of the ANS. Most cases of orthostasis are seen in patients with some degree of autonomic impairment, which is very often associated with disorders like Parkinson's, diabetes mellitus, or even old age. And this on top, combined with medications that can reduce blood pressure, can further trigger it, especially the centrally or peripherally strong vasodilators that the patient may be given along with them. So the commonest comorbidity I was touching upon, why this topic becomes so important, and I must salute Dr. J.C. Mohan to include orthostatic hypotension in a seminar on hypertension, because this is something that as a cardiologist you should not be missing out upon. I mean, as a physician, you may be excused to some extent to miss it out on, but a cardiologist should not be missing on autonomic assessment of an autonomic nervous system assessment. So hypertension, most common comorbidity, it's present in almost 70% of the patients of OH. And 70%, conversely speaking, it's present in 10% of patients referred for hypertension evaluation. Diabetes is a cause of peripheral and autonomic neuropathy is present in another 40% of the patients. And other comorbidities often associated would include various causes of peripheral neuropathy, heart failure, coronary artery disease, stroke, and Parkinsonism. And OH increases 2.6-fold the risk of fall and injuries, and hence the old age associated complications that may ensue. Its presence doubles the risk of CKD. It's an independent risk factor for CV morbidity and mortality, including all-cause mortality. Overall annual rate of OH-related hospitalization is almost 36 per lakh US adults, and 233 per lakh in those with more than 75 years of age, which goes on to say how frequent and often missed and underdiagnosed and undertreated this remains as a problem in community. Majority of patients with OH in cardiology are having usually milder form of autonomic dysautonomia and superimposed with other aggravating factors, which is very often the medications that they are given. So basically, the anatomy and physiology of blood pressure control is between the afferent and the efferent pathway. I thought I'll touch upon the basic pathophysiology, and there was a good review article on JACC in 2018, which talked about the afferent and the efferent pathways, which modulate and regulate the normotension on postural change, which gets impaired in neurogenic orthostatic hypotension. The afferent pathways are, of course, mediated by the 9th and 10th nerve, as we know, and the efferent pathways are mediated through the dorsal root ganglia to the sinus, through the 10th nerve to the sinus node, and in between, of course, through the medulla and the spinal cord communication, you have sympathetic ganglia coming into play, which regulates the peripheral release of noradrenaline from the blood vessel, and hence their vasoreactivity to accommodate for rise or compensate for the blood pressure. Now, this imbalance is what actually triggers the inhibition that comes into from the spinal cord through the sympathetic ganglion, through the CVLM, is what actually gets impaired, or it can be impaired even through the dorsal root ganglia to the 10th nerve fiber, which can be responsible for the dysautonomia. So as we know that the normal blood pressure, as the patient stands up, the blood pressure drops slightly, and to respond to that, the blood vessels, as they expand, would trigger brain to sense the volume displacement and causes vasoconstriction, and also compensates by increase in the heart rate to attain normotension. Now, this is what is blocked or impaired in patients who develop orthostasis. The arterial cardiac baroreflex feedback loop, as we know, includes the baroreceptors through the efferent 9th and 10th, through which they have a regulatory set point, which is usually defined by the pathophysiology of what we call normality of 120/80, but which is not the case for central pressures. Central pressures have much lower values, and that's what determines your central set points, which are usually 110 and 70. So the peripheral pressures actually don't represent this orthostatic regulated mechanisms, and that's why now people talk about controlling central hypertension or regulating central target of blood pressure, not the peripheral pressures, which again in terms mediates the peripheral resistance and cardiac output to regulate the blood pressure. So the etiology would vary after understanding the pathophysiology, we can say, based on the drug-induced, volume-related, neurogenic, which can be primary or secondary. Drug-induced very often are the centrally acting strong drugs like clonidine or methyldopa, or strong vasodilators like hydralazine or minoxidil. Other vasoactive drugs like nitrates, especially along with PDE5 inhibitors, antidepressants like tricyclics, which is the amitriptyline or imipramine, or Parkinson's drugs. Like this is very common. A lot of cardiac patients would be on, elderly patients can be on levodopa. And on top of that, when you're giving drugs like diuretics or even hydralazine in patients with CKD as a treatment of heart failure, you can actually end up with issues which can lead to a development of worsening of the orthostasis. Relation of depletion of total or effective intravascular volume would include bleeding, dehydration, diarrhea, vomiting, diuretic action, heart failure, venous pooling. While neurogenically speaking, primary would be Parkinson's, pure dysautonomic failure, multiple system atrophy, dementia with Lewy bodies, familial dysautonomia, and GBS, while secondary would include diabetes, CKD, essential hypertension, amyloidosis, autoimmune disorder, paraneoplastic syndrome, endocrine disorder, HIV, CVA, or sometimes even patients with Chagas disease, hepatitis C, or even B12 deficiency, which is one of the curable and preventable disorders. So neurally mediated hypotensions, which are primarily either dysautonomic or you can call them idiopathic, or you can have low blood or drug side effects or other causes. Hence, the primary autonomic failure is primarily an overlay or overlap of neurologic as well as cardiovascular disorder, which includes dementia with Lewy bodies, Parkinsonism, multisystem atrophy. But this pure autonomic failure, as we call as Bradbury-Eggleston syndrome, is something that cardiologists should be pretty much aware, probably more aware than the neurologist. Diabetes, amyloidosis, spinal cord injury, alcohol, hemorrhage, diarrhea, aging, etc. are the other etiologies. So the major mechanisms I've already touched upon. I'll come to now the other aspects, the carotid sensory aspects and the consequences of lightheadedness and dizziness apart. The autonomic failure, or as we call as NOH, where we'll be talking about the pathophysiologic orthostasis being mediated through the hemodynamic receptors. And this is again just the repetition of hypothalamus, how it's integrated along with the peripheral vasoconstrictor and the chronic chronotropic incompetence that may encounter in patients in impairment of development of autonomic regulation in the change of posture and regulating blood pressure. Medication wise, I've just finished a long list of it, but this list can not exhaustive. I mean, it's much more than that. It can start from A of alpha, B of beta, and end up, with T of tricyclics. And the list is long, and you can name a drug which has a potential to cause volume depletion or heart rate regulation or vasodilatation or central regulation of sympathetic flow. All of them can actually be responsible for development of orthostasis. Aging, of course, is because of the worsening of the autonomic regulation itself may be responsible. Most of the patients do present with symptoms from cerebral hypoperfusion, which includes weakness, dizziness, visual blurring, loss of consciousness, which is, of course, the syncope, and that brings the patients to you. Fatigue, cognitive slowing, neck pain, headache localized in suboccipital, cervical, posterior cervical, or shoulder region. The coat hanger headache, as it is called, which is reported in 50 to 90% of the patients. The diagnosis. Postural is diagnosed within 2 to 5 minutes of quick standing, which is the classical OH, as I mentioned. one or both should be present, that at least 20 systolic or 10 diastolic falls within 5 minutes. So this is early or the in classical OH, as we know. The delayed OH, as I said, usually can end up, beyond 5 minutes, and sometimes it's usually beyond 10 minutes. So how do we assess? We look at the blood pressure, heart rate after 5 minutes of supine, repeat their blood pressure, heart rate after 3 minutes of standing, and alternatively after 5 minutes seated, and repeat it after 1 to 3 minutes of standing. At home monitoring, again, you can ask the patient to look again for the same prior to arising in the morning, and repeat the same after 3 minutes of standing. Repeat it while standing when symptomatic, and check orthostatic vitals for 7 days prior to the appointment. That's the other way. So once you want to review the medication, reduce the same and modify them, and then evaluate cause for the secondary OH, which would include the potential causes which I mentioned, and review the cardiac history, perform an ECG, and you can do a QSAT or thermoregulatory sweat testing, pseudomotor testing, catecholamine levels, autonomic testing, or 24-hour ABPM. I don't know how many of you use it, but Canvin machine is one machine that I use. It combines all these parameters into one machine for orthostasis assessment, and that also helps you to know whether dealing with a parasympathetic abnormality or a sympathetic abnormality. Though the drug modification may not be much, but then you can always diagnose as a primary autonomic failure if both are impaired. So, as I said, if you can find a symptomatic abnormal blood pressure fall, it's a class 1 way of diagnosing syncope due to OH. While if the patient's history of syncope is not all the features are highly suggestive, then it may be called as class 2A, while asymptomatic falls are 2A or 2B according to possible features in the history. No fall, of course, then it remains untrue and not negative. So active standing, as per the guidelines in the European Heart Journal, intermittent determination of blood pressure and heart rate while supine and active standing 3 minutes are indicative of initial syncope is class 1C. Beat-to-beat non-invasive BP heart rate measurement may be preferred when short-lived variation are suspected is class 2BC. Diagnostic criteria, income of syncope due to OH is confirmed when the criteria that I defined is 1C, while syncope due to OH may be considered possible when an asymptomatic fall of BP of baseline more than 20 or diastolic more than 10 or a decrease of less than 90 and symptoms are less considered OH, and it's class 2BC as per the guidelines. Tilt table testing is something that we very often know of and have been using in our residency, even otherwise in practice. But remember that all of them are class 2. None of them is class 1. Tilt table testing should be considered in patients with suspected reflex of POTS or PPS, POTS being postural orthostatic tachycardia syndrome, PPS is psychogenic pseudosyncope. All of them can be differentiated, but it's 2A level B, not 1. And tilt testing can be considered to educate to recognize, that is also 2B. Diagnostic criteria of to be considered in tilt table producing symptoms along with the characteristic pattern is still 2A, because a lot of false positives can develop with this. So additional advice would be a negative does not exclude it, while sensitivity, specificity are acceptable levels when measured in patients with vasovagal syncope and healthy controls. In usual clinical settings of syncope and uncertain origin, tilt table testing suggests that the presence of hypotension susceptibility, which may exist not only in reflex syncope but also other causes of syncope, include some form of cardiac syncope. There are two types of responses which we know. One is the cardio-inhibitory and vasodepressive, or third can be combined or mixed, as we know. A positive cardio-inhibitory response to tilt predicts high probability asystole, spontaneous syncope. This finding is relevant for therapeutic implications for pacing. However, vasodepressive or a mixed response or even a negative cardiac response does not exclude the presence of asystole during spontaneous syncope, and this should be borne in mind. So how to interpret tilt table is also pretty important, and it should be helpful in segregating syncope from pseudosyncope, as we know of. Basic autonomic assessment in patients would include Valsalva, which would be considered in patient with suspected neurogenic syncope is 2A. Valsalva maneuver considered for confirming hypotensive tendency by some form of situational syncope should be 2B. Deep breathing test should be considered for assessment as 2A. Other autonomic functions, which is the Valsalva ratio, that is the 30th to 15th beat ratio, cold pressure test, sustained grip test, mental arithmetic test, they should be considered in suspected neurogenic OH, which is 2B. ABPM to detect nocturnal fall is actually the only therapy or only method to assess autonomic, which is recommended by European Society of Cardiology as class 1. So amongst all the tests, we thought maybe the tilt is better, but it is actually the ABPM, which is the best method to assess autonomic when you can document the time and the event that happened as the posture change to document the same. HBPM can also be used, but it's 2B right now. But I'm sure with new devices, it may come actually to be better. Now, responses, of course, as we know, mixed is the drop in the rate, not less than 40. If the drop is below 40, then the drop lasts less than 10 seconds and the blood pressure drops below heart rate. That's one of the quarters type 1 type of response. 2A is cardioinhibitory without asystole. 2B is cardioinhibitory with asystole. Type 3 is vasodepressive, that the heart rate does not drop more than 10%, but the blood pressure falls. And the exceptions to 1 is the chronotopic incompetence, which is there is no significant increase in heart rate during the tilt test. An exception to is posture POTS, that is excessive increase in the heart rate, which is greater than 130 beats, both initially and throughout the tilt, before the syncope happens. Then that is one that we should be aware of. So tilt table testing would include patients with orthostatic hypotension, postural tachycardia, and reflex syncope. So by definition, orthostatic hypotension is defined as gradual sustained decrease in blood pressure, as I mentioned. Postural tachycardia would be heart rate rising by more than 30 beats in 10 seconds with no change in blood pressure, while reflex syncope will be sudden fall in both heart rate and blood pressure. So this is the pattern that you find between the heart rate and blood pressure between the two as to how they cross over between the two pathophysiologies. EV reflexes usually are abnormal in patients with orthostatic hypotension, while they are pretty much functional and good in POTS or reflex syncope. There are variants. The classical I mentioned to you, initial OH, which is the fall in blood pressure on standing, more than 40 with BP spontaneously and rapidly returning to normal with period of symptoms less than 30 seconds, while reflex or vasovagal is initial normal adaptation followed by a rapid fall in venous return, which you can pick up on tilt table. Delayed OH plus reflex syncope all can be picked up. POTS, again, you can pick up, and severe orthostatic intolerance, not syncope with marked increase in the heart rate and instability of BP also can be picked up. Complications would include, as I mentioned, CV and all-cause mortality. Orthostatic hypotension can cause falling, which can significantly associated with morbidity, particularly in frail elderly patients. Orthostatic hypotension predicts mortality in middle age, as from the ARIC study, which shows that the unadjusted socio-demographic risk factor or health condition apart, the association between all-cause mortality and OH is pretty strong. Within first 2 years, almost 3 times in unadjusted. But if it's adjusted for socio-demographics, still remains 2.3 times. And even comorbidities, if baseline were excluded, it still continues to be an independent predictor of all-cause mortality. This is another study which talked about a meta-analysis published in the prospective observational studies, which looked at the OH as a risk factor for MACE. And you can see that it showed that it was significantly associated risk of all-cause death, incidental CHD, heart failure, and stroke, with a relative risk ranging from 1.5 to as high as 2.25 for heart failure. So heart failure, stroke, incident CHD, and death all are high in a large meta-analysis of more than 1 lakh patients. Of course, it's a recurrent falls among the elderly, and hence more incidence of fracture is also found. So how do we treat it? Symptom relief is one thing, but we need to treat non-pharmacologically and pharmacologically. Algorithms would include modify or remove medication that worsen. Non-pharmacological steps would include fluid, salt, compression, stockings, abdominal binders, exercise, etc. Pharmacological methods would include fludrocortisone, midodrine. Midodrine has now gone off patents. A lot of companies have come with it. Droxidopa is not yet available. Pyridoxstigmine has a lot of side effects, so it's not used. But a lot of people, we do have now midodrine available, and that's one therapy that we all can look for in future. And of course, combination pharmacology. Non-pharmacology would be first and foremost to remove the offending drug that's directed for the chronic orthostatic hypotension. So acute due to volume depletion should be treated with volume repletion. Lifestyle modification arising slowly avoiding straining, coughing, walking in hot weather, large sweating, maintaining hydration, raising head level for 10 to 20 degree, which decreases the renal perfusion and hence the RAS activation, use of custom fitted stockings, abdominal binders, waist binders, a peripheral and the splanchnic circulation being modulated by the same are some of the lifestyle modifications that we need to teach our patients. Increase the salt and water intake. Most of these patients we tell to drink 3 to 5 liters a day, and they can have extra pinch of salt, includes salads, includes pickles or papads in their diet. Avoid large meals, have small frequent meals, low carb diet, stop alcohol, not minimized, probably stop alcohol, drink water with meals, and avoid activity of suddenly standing after eating. So the algorithm of neurologic treatment, as I mentioned, apart from these compressive garments, would be the first symptomatic drug, which is either midodrine or droxidopa. Add agents which can have even central effects like the fludrocortisone or even vasopressin analogs. There are inhalers available now. And if you're run out of them and still patient remains symptomatic, then pyridostigmine is one other therapy. Atomoxetine, I'm not sure if it's available in our country. So after educating and you've stopped the vasoactive drugs, you can choose counter pressure measures, garments, head tilt training, midodrine, and fludrocortisone. This is from the European Journal of Cardiology. Now, midodrine is a prodrug which is hydrolyzed to its active agent by disglyamidodrine, which is a constrictor of both the peripheral arterial and venous vessels through alpha-1 adrenoreceptor agonism. And it increases standing blood pressure in dose-dependent pattern with peak efficacy at 1 hour, coinciding with peak plasma level. Midodrine does not stimulate cardiac 1 beta receptor and hence does not cause, neither does cause cross the blood-brain barrier or cause CNS side effects, and that's why it's a very good drug to choose. Its adverse effect would be hypertension, of course. It can cause pilomotor activation with itching in the scalp, which very often they come with. And a lot of these patients have prostate, so they can come with urinary retention. So that's something that we need to remember. This is a trial which was published in 97 way back, where they studied 10 milligram 3 times a day, and which found that the blood pressure increases by 21 systolic with improvement in Giddiness score. This is another paper where they talked about the neurogenic orthostatic hypotension in a placebo-controlled fashion with midodrine in the age exam, where the droxidopa is basically nothing but a precursor of dopa decarboxylated pathway modulated norepinephrine production, while levodopa will convert to dopa and dopamine. The droxidopa will convert to norepinephrine, and hence levodopa, though it's more of a hypotensive drug, droxidopa is actually not a hypotensive drug. These are the trials with droxidopa, 7 to 14 day studies. Kaufman and Bigoni are the two trials which they found out that the composite endpoints was reduced in the Kaufman study, where the headache, dizziness, fatigues, falls, supine hypertension, all were significantly reduced. And this is the summary of the drug options. Midodrine, 10 milligram 3 times a day is the maximal tolerable dose. But of course, we know we start with 2.5 milligrams. Droxidopa, 100 milligram 3 times a day, top titrated, 1800 is the maximal dose. Fludrocortisone, 0.1 milligram daily, up to 3 you can give. Pyridostigmine, of course, neurologists have been using a lot of times in myasthenia gravis, which is acetylcholinesterase receptor inhibitor, and it is 60 milligram 3 times a day. Atomoxetine is 18 milligrams daily. It's a norepinephrine reuptake inhibitor. Pseudoepinephrine, 30 milligrams daily, and octreotide or somatostatin analog can sometimes also be used. Of course, when the hypertension comes in these patients, you need to know that the medication withdrawal should be gradual. BP lowering agents should be used preferentially, would be ACE, ARBs, and CCBs. And patients with risk of falls, diuretics, beta blockers, they should be avoided. Fludrocortisone can cause hypokalemia and headaches. Pyridostigmine can cause abdominal cramps. Midodrine can cause scalp itching and retention. So we know which subgroup of patient we need to avoid what. Heart failure, you would avoid fludrocortisone. Water boluses can be short-acting, and droxidopa is not very easily available and it's very costly. So postparental hypotension, I'll touch upon some of the variants and special conditions. Postparental hypotension is something that the patient has a blood pressure nadir within 30 minutes after the last meal, and the relief is done by acarbose. So the therapy here is not a cardiac drug, but a diabetic drug. So in postprandial hypertension, you would choose alpha glucosidase inhibitor, acarbose. In patients with hypertension, as I mentioned, 70% would have this associated hypertension in them. 10% of which, when they visit, they have hypertension, and 40% diabetics would have the options, as I clearly mentioned, what to avoid and what to give. Abdominal compression is one of the best if that suits the profile, and pressor agents, while urging patient not to lie down immediately after taking them. In heart failure, you would be very cautious, and the drug of choice would be droxidopa, because which has both alpha and beta agonism. That's got less heart failure exacerbation as compared to mineralocorticoid, and hence you would try to take off the diuretic and try to add droxidopa rather than give fludrocortisone, because it can worsen volume retention and worsen heart failure. So orthostatic hypotension, explanation and diagnosis and provision of reassurance and risk of recurrence and avoidance of trigger is class 1 level C by ASC guideline. Adequate hydration salt intake is also 1C. Modification of hypotensive drugs is 2A. Isometric PCM should be considered. Abdominal binders, head up tilt sleeping, midodrine considered, and fludrocortisone considered are all 2A. So this is my summary. The last slide, syncope. You look at the postural fall. It's neurogenic OH, then water ingestion should be increased. Compression, abdominal counter pressures, midodrine, droxidopa, fludrocortisone, salt intake, octreotide, pyridoxyticmine are various options. Drug options would include reduce or withdraw the medication if that is the cause. In patients who are dehydrated, simply giving a lot of salt and water would solve the problem. Thank you. Thank you very much. Over to the chair. Thank you for patient hearing.
Thank you, Professor Kamal Sharma. We had actually an excellent discourse on orthostatic hypotension. And let me just see. We can gallery view. Yeah. And I think there are plenty of questions which are being directed to you, but what we will do is we'll ask Professor Mahajan to make a presentation of his case, and then we'll take the questions in a combined manner. That way, you, Professor Mahajan, and myself can participate in answering questions to the best of our ability. So I will request Dr. Ajay Mahajan, who comes from Mumbai, and I already said is a great teacher, to talk about his case of orthostatic hypotension.
Good evening, sir. Presentation. It's very easy for me to present a case of orthostatic hypotension. So the most important thing is that next. So my patient, now he is 84 years old, referred to the cardiac arrhythmia services for implantable loop recorder to exclude arrhythmia as a cause of recurrent syncope. 4 months ago, he presented to general practitioner with recurrent syncope and referred to cardiology. 3 months ago, he was sent for echocardiogram and Holter monitor. Both were unremarkable and referred for implantable loop recorder and no definitive diagnosis. So this is a classical thing. Elderly patient who are presenting with the syncope, and they are specifically because of the syncope, they are referred to the cardiologist to find out what is the cause. So when always the syncope is always because of decrease in the perfusion of the brain. Syncope is the disease because of decrease in the perfusion, and the causes of decrease in the perfusion at this particular age is one of the most common causes. Some conduction disturbances like a complete heart block or tachycardia syndrome or atrial fibrillation. Second thing is hypersensitive carotid sinus. Sometimes because of that one may get syncope. And third thing is neurogenic orthostatic hypotension causing syncope. So my patient is Parkinsonism, and he was having some cognitive impairment because he is 85 years old. He was having some labile hypertension and he is only on medications for levocarbidopa. So all these patients who are elderly, who are having labile hypertension, most of the time they are maintained on the obligatory medicines for the treatment of diseases like Parkinsonism. And because he is a labile hypertension, so most of the time they are not on any antihypertensive management. So there is no prior history of CAD or cardiac arrhythmias. Syncopal events were brief, typically lasting for several seconds with a rapid return to consciousness, gradually increasing the frequency and now occurred several times a day. Patient did not report any symptom. However, family member reported that patient looks like he was on going to faint during the events. So the most important thing in this elderly age group of patient is you have to ask the history to the attendants also, because the person who is observing the symptoms of the syncope is one of the most important person, because at the age of 85 with the Parkinsonism, with the impairment in cognitive functions, it is sometimes not possible for the patient to recollect what is going to happen. And that particular thing you have to take the history from the attendant. So here, after knowing the neurocardiogenic syncope, one can pinpoint the diagnosis. But to pinpoint the diagnosis, one must suspect the reason for this particular thing. And it is very common in these elderly patients. Next. So the most important thing is we have to find out what is the orthostatic vital sign. And the most important orthostatic vital sign in this particular patient is fall in the blood pressure. So we have to take the blood pressure in supine, and then we have to take the blood pressure in standing, after standing for 5 minutes. And when there is a fall in blood pressure around 20 or 20 to 30 millimeters of systolic and around 10 to 20 millimeters of mercury diastolic, it is suggestive of neurocardiogenic syncope. Next. So the most important thing is that this is because of blunting of the autonomic nervous system, and because of baroreceptor sensitivity is blunted in those particular patients, and they, with the change in the posture, they doesn't maintain the blood pressure, and because of sudden decrease in the blood pressure, there is a decrease in the perfusion of the brain, and which ultimately lead to the syncope. But when the time passes, the blood pressure maintains and the syncope get reverted. So patient will get a recurrent syncope in this particularly elderly age group, and it is a classical of neurocardiogenic syncope. Another thing is that in this particular patient, when we are doing orthostatic blood pressure, orthostatic vital sign recording, the pulse rate is constant. So that is very important. When the pulse rate is relatively constant, that means it is not related to any hypersensitive carotid sinus, because in hypersensitive carotid sinus you will get a decrease in the pulse rate or bradycardia, or it is not related to any transient arrhythmias which is producing decrease in the heart rate, ultimately leading to the decrease in the blood pressure. So the cause of the fall in the blood pressure is not a cardiac, because heart rate is constant, stroke volume is constant, but because of vasodilatory response or because of blunted autonomic response, there is a fall in the blood pressure, and that is the reason for decrease in the perfusion of the brain and leading to the syncope. Next. So this is the classical tilt table test finding, which already Dr. Kamal Sharma had described. So in tilt table, we may get a different type of response, but sometimes it is very difficult to diagnose this particular condition with a tilt table. Next. And now the tilt table tests are also not that much frequently available. The most important and bedside test one can do, that is a Valsalva test. And the Valsalva test, there are 4 phases: phase 1, phase 2 and phase 3. So during the most important thing is the straining phase and release phase. So at the time of straining phase, there is slight increase in the heart rate with slight decrease in the blood pressure. That is a normal response. And after release, there is a sudden increase in the blood pressure. So that is a normal response. So what happens in the patients with autonomic nervous system or autonomic disturbances, there is a heart rate is not picked up. There is slight heart rate response is blunted, but the Valsalva strain phase lead to the decrease in the blood pressure, both systolic and diastolic, and during release, the blood pressure doesn't come up fast. It takes more time to come up fast. So it is a delayed response while release. And that is one of the diagnostic thing for this particular condition, neurocardiogenic syncope. Next. So already Dr. Sharma sir discussed this particular thing. So the most important thing is suspicion. So we have to take a proper history, elderly patient with a pre-syncope or during standing or upstream while lying. So the most important thing, we have to find out is there is any possibility for orthostatic hypotension in this particular patient, and then we have to come to the diagnosis of orthostatic hypotension as a cause of syncope in this particular patient. Next. So the diagnosis is decrease in the blood pressure with the posture. That is the thing. And most rarely it is because of the disease process, or it might be because of the drug which is taking for the treatment of Parkinsonism, that is levodopa. Next. So can we stop levodopa in this particular patient? So the most important thing, suppose we stop the levodopa, then what will happen is Parkinsonism will not respond and he will become a bedridden. There will be more rigidity and the life will be miserable. So you cannot take a levodopa because it is obligatory medicine for the Parkinsonism, but we have to find out some additional substitute to take care of his symptoms of postural drop in blood pressure and how to come to the conclusion. Next. So already this slide was discussed in previous lecture, but still I want to discuss it once more. The most important thing is we have to find out is there is any cause related to the depletion of the volume. The most important thing is bleeding, dehydration, diarrhea, vomiting, diuretic use, heart failure and venous pooling. So that is one of the most important thing in elderly. So elderly patients, if they are hypertensive, sometimes they are prescribed with the diuretics overuse, or if they are heart failure, then they might previous slide please. Previous slide please. So the most important thing is we have to find out is there is any volume depletion in this particular patient or not. Then another thing is that what are the co-medications he is taking. So if he is taking aggressive vasodilators, then we have to think about those particular things. So for the treatment of hypertension along with the Parkinsonism, where the treatment of Parkinsonism is very, very obligatory with the syndopa. So then we have to slightly change the treatment of morbidities like hypertension. There we have to slightly avoid those drugs which are acting centrally for the treatment of hypertension to get rid of this particular thing. Sometimes, rather most of the time, Parkinsonism plus syndrome. So Parkinsonism with autonomic nervous system involvement, or Parkinsonism plus, or like some patients when there is a autonomic nervous system involvement secondary to one of the most common causes, diabetes. So diabetes, so all these things we have to keep into consideration. And then we have to write a co-prescription to take to treat this particular condition. Next. So the most important co-prescription depending upon the patient's treatment. So here my patient is only on syndopa, that is for the treatment of Parkinsonism, and he was not for any other drug for the treatment of comorbidities like hypertension or diabetes or something like that. So because of this, we can directly start with the drug which is available in the market like a midodrine. We can start with the 2.5 milligrams a day for 2 to 3 times a day depending upon the patient's activities, and then we can up titrate or we can make the dose static for the thing. Another important thing is that the education of the patient and education of the family and patient's attendant. That is one of the most important thing which is required to treat this particular thing in elderly patient, because most of the time these elderly patients, they are having multiple comorbidities, joint involvement. Parkinsonism itself is a locomotor disease involvement, and in these patients, because of the fall in blood pressure, if the patient fall down, the chances of getting a fracture and other problems are very high, and we have to be very, very careful. So for that particular thing, we have to tell the patient's attendant to take care of the patient with a proper compliance to the drug, and we have to treat these patients with the drug which is just available in the market like a midodrine 2.5 milligram, or sometimes if required we have to go with some non-pharmacological things like stockings and increase in the dietary salt if the patient is not hypertensive, and that should be the management to this particular patient. Next slide please. So already this slide was discussed with Dr. Sharma. So this is the protocol to treat the neurogenic orthostatic hypotension. The most important take-home message from my case is that high level of suspicion, proper taking history, and sometimes at this particular age of the patient, elderly patient, because of they are having cognitive impairment, we have to take the history with the attendant. And all syncopes in elderly are not because of rhythm disturbances. Sometimes they are because of decrease in the vasomotor tone, and which is very common because of autonomic nervous system involvement in the elderly age group of the patient. With this, I am stopping here for my case, and then we can have some views of Professor Mohan sir and Dr. Kamal Sharma sir and have some discussion. Thank you.
Thank you, Dr. Mahajan. I think you made a point, presented a reasonably good case. And let me point out before we go in any more details that orthostatic hypotension is a real clinical issue which is ignored by physicians and cardiologists alike. They don't understand it that well, and they don't really investigate that well. And that is the tragedy, actually, that we are not taking care of these patients pretty well. And I think a lot of us are at fault as far as ignoring orthostatic hypotension is concerned. And even if we have diagnosed it, our algorithm for managing it is actually lackadaisical. More salt, more fluids, and of course compression stopping, and that's the end of the story. And sometimes midodrine. I think there is much more which needs to be done, and you have both taken us through this entire gamut of orthostatic hypotension, and it is a serious issue. Actually, 5-6 days back, actually, I had a post-CABG 84 years old patient, just 4 days back. And I did an angioplasty of native LAD and sent him home. He actually had a fall yesterday, brought to the hospital, was found to have orthostatic hypotension was the issue, but he had a scalp hematoma. So now the issue, there was a big issue about continuing aspirin, clopidogrel, the ticagrelor in this guy because he kept presenting with ACS. And so the orthostatic hypotension has to be seen in a wider context, what all can happen to patients. And so let us go back to the questions which our viewers have, and we'll start with the first question. I think the second question will come back to the first question by Dr. Ajay Singhal, and it says, beta blockers have least potential for orthostatic hypotension. However, they are limited by efficacy in elderly people due to sclerotic arteries. So, to Dr. Kamal Sharma, what is your opinion on selecting beta blocker in elderly patients with hypertension and orthostatic hypotensive episodes?
Yeah, so I think it's a very long question. I think we need to firstly take what beta blockers stand in hypertension as. Now, if you're talking as a class, we know from Bu Kalberg's meta-analysis, we know from Shripal Bangalore's meta-analysis that they are a very poor drug because they may alter. People talked about atenolol as a fantastic drug. You give atenolol and peripheral pressures are okay. But the problem was they did not lower the central aortic pressures. And when you don't lower a central aortic pressure, you don't prevent end organ damage. And that is why the beta blockers fell out of vogue. Now, if you talk about new generation beta blockers, maybe you can argue they have nitric oxide property, this, that, but then we don't have evidence as of now. So their antihypertensive efficacy as measured by peripheral pressures may be good, but they are not good centrally pressure lowering agents, and hence the beta blockers are the fourth line as we know from the guidelines. Number two, what about its role in patients with OH? No, because in patients with OH, they are basically dependent on the sympathetic drive, which is the cardiac output being maintained either by blood pressure and the heart rate and the product of the two. If you're going to blunt their heart rate response to orthostasis, which may partially be intact or may be lost completely, you will actually have worsening of the symptoms rather than preventing the same. And hence, beta blocker is not the drug that you would choose, especially in elderly. When we talk about beta blockers to choose, we choose about young patients with high sympathetic drive, patients like mitral valve prolapse, tall, lanky guy, heart rate of 100, 110, presenting with hypertension. That's where we would still choose beta blocker. But these patients, they are dependent so much on heart rate as a compensatory mechanism to their orthostasis that if you blunt that with beta blockade, the more selective you would become, maybe you'll still not be able to cut down on the response to the heart rate. It may not be a good choice to use. Hence, the guidelines talk about either ACE, ARBs, or a CCB as an antihypertensive of choice, not a beta blocker, not a diuretic, and of least to speak the central.
Good. Dr. Mahajan, your comments on this particular question. Beta blockers, management of orthostatic hypotension in a patient, elderly person with known hypertension. Anything different?
My take is slightly different here. So the most important thing is we have to find out that the patient is having autonomic nervous system impairment in this particular condition. So what is the basal heart rate in this particular patient? If the patient is tachycardic relatively more than 80-85 beats per minute, so I'll still prefer using a cardioselective beta blocker along with AC inhibitor or ARB or with calcium channel blockers for these patients. But I will not say total no for beta blocker. I will go case by case. If there is a baseline tachycardia, then always a beta blocker should be considered in this particular thing. The another important thing, as far as this orthostatic hypotension is concerned, so Dr. Sharma has already told what is the response in these particular patients as far as the ambulatory blood pressure measurement monitoring. So if ambulatory blood pressure monitoring shows nocturnal hypertension, so that is the most important thing. So if there is a nocturnal hypertension without a fall in heart rate, so there beta blockers are relatively better taken, because actually with a sleep, sympathetic tone should go down and there should be decrease in the heart rate. And that thing, if it is blunted on ambulatory blood pressure monitoring, then I might think of continuing with the cardioselective beta blocker in elderly also for this particular condition.
So let me actually, we'll have Dr. Sharma's final opinion, but let me actually give you my 2 cents. Number 1 point, as age advances, people become what you call V-type hypertensive, volume dependent. They are no longer R-type, they are no longer renin dependent, as John Lara suggested 60 years back. To him and his wife Suzanne, we give the credit of describing R-type hypertension and V-type hypertension and the combination. So in any case, beta blockers are very ineffective as antihypertensive drugs in elderly. Besides, of course, there are pseudo-antihypertensive for peripheral blood pressure, as Professor Kamal Sharma said. But number 3 point, which you mentioned about highly selective, more selective a beta blocker is, less is the unopposed alpha activity. So, in fact, if you really want an unopposed alpha activity, a propranolol would be a better choice. But unfortunately, we also know that propranolol is something which will have a lot of side effects in elderly people. My point, I'll get back to what Dr. Sharma said, that in this particular patient, I need to evaluate the patient very carefully. What are the drugs he's taking for benign enlargement prostate, and you rightly said about autonomic function, and of course the issue of what other antihypertensive drug he's taking. Is it by any chance that the patient is on doxorubicin, labetalol, things like that? And a lot of people, we should not forget that the postural hypotension is well described with these central sympatholytic drugs also. The moxinidine and, of course, alpha-methyl-dopa we don't use any longer, but moxinidine and clonidine certainly are capable of causing. I would probably go through that in detail and then come through. But I think let's take final take from Professor Sharma, and then we move to the next question.
No, I endorse completely what Professor Mahajan and Professor Mohan have said. I completely agree with your point. I think you need to individualize, of course, but generally speaking, you would avoid a beta blockade, as you mentioned. So if you have exhausted, say, ACE or an ARB along with the CCB, and still patient is hypertensive and still getting syncope, orthostatic hypotension, and then you've done a tilt test and it shows that their heart rate is not dropping, it's only purely vasodepressive. And then if the resting heart rate is more than 80 and still you want to choose a beta blocker, maybe in that selective group, I'm okay. But if generally speaking, blanketly speaking, choosing an antihypertensive, not a beta blocker.
So we come to the next question, and that is by Dr. Dayanand Kumble. And the question is, simple orthostatic hypotension in long-standing diabetic, the patients are prone to develop sudden cardiac death. So the question is, people who are diabetics with simple orthostatic hypotension are prone to sudden cardiac death. when submitted to any type of surgery. What is your opinion, Dr. Sharma?
Yeah, I think what you're talking about is trying to bring out a very important aspect. I'm not even touching upon that they have a silent ischemia, they have silent arrhythmia. I'm just talking about your today's topic of orthostasis. Now, we have to understand that in these subset of patients, maybe not the orthostasis is actually a manifestation of dysautonomia. These patients have autonomic imbalances, autonomic disorders, which have not been looked into, and they are going to respond with a drastic fall or rise in blood pressure for anything that's going to challenge their autonomic system, which includes volume depletion, giving of anesthesia, coming out of anesthesia, intubation as a procedure, drugs which are given as an anesthetic agent. All of them are going to play an important role with their autonomic dysregulation being manifested during the surgery. And I'm not even touching upon the other manifestations that like arrhythmias or like sudden deaths because of coronary etiology or pulmonary embolism. So what you're trying to bring out is that it's very important that when you assess a patient preoperatively for a major surgery who's a diabetic, you should make sure that not only you're looking at CAD risk, not only you're looking at arrhythmic risk, you're also looking at dysautonomic risk, and which would include very simple tests like orthostatic fall in the blood pressure. You don't have to do a full Canvin test, but at least look out that you're not dealing with an orthostatic pressure, because the surgeon and the anesthetist are going to be chasing their 120/80 goals. In a patient who's dysautonomic, and if you're doing an induction, you would start with something 30 plus in that range. So this patient might be loaded with antihypertensive and he's made so-called normotensive, and the central pressures are actually in the range of 90, and then you do an induction, and then there is a hypoperfusion and a silent CAD, and then he has an arrest. So that's the one thing with regards to today's topic that I thought that we should bring it out. And I think that's one of the reasons why you get a lot of, maybe they are bradyarrest, maybe they are tachyarrest, maybe they are hypotensive arrest, but dysautonomia is one thing that perioperatively should also be assessed apart from the CAD. And
but we also have to accept one fact, that in practice, the kind of equipments all of us use, measuring standing blood pressure is cumbersome.
Absolutely.
And a lot of us don't do it.
True.
Most of us don't do it. Let us accept the fact. And it is an important issue, and we probably would do it if the patient is symptomatic. Then we'll think maybe orthostatic hypotension is the cause. But as somebody rightly pointed out, there may be a good number of diabetics who have a reasonable amount of hypotension, may not be symptomatic, and they may also be at risk, and also we need to take care of them as well. They may be at a slightly less risk, but nevertheless, they won't behave like normal people.
Absolutely.
Good. So there is another question which has been asked, I think by Dr. A.H. Patel, who says, does sleeping in head-up position help in controlling or reducing orthostatic hypotension?
Yeah, I think I answered that. The 10-degree rise, that's because that you want the renal perfusion and the carotid receptor resetting, which can help. So yes, keeping 2 bricks. That's, I mean, in our residency, we were told that tell the patient to sleep with 2 bricks kept under the head end of the charpai, and now we say that you tilt the bed. Now the more modern beds can be tilted, or you sometimes ask them to, keep the slab under the head end of the bed, because 10 or 15 degrees of upregulation will have more amount of fluid to the lower limb. Renin secretion dependent regulation through the kidney perfusion can also be improved upon. And baroreceptor being primed for hypoperfusion because of the gravity, whatever little, and resetting the baroreceptor reflex mechanism can help. So yes, those are the small things that we also need to talk and discuss with our patients who are as an important non-pharmacological measures in patients, like the abdominal binders, as I mentioned, the stockings, the extra salt in their diet, vagal training, as we call. A lot of times we'll have to say, don't start as you feel like trying to pass urine in the middle of the night. You must first sit up and sit in your bed for 4 or 5 minutes, then only stand with a support for another 4 or 5 minutes, and then walk to the washroom and pass urine. Because a lot of these patients who have their washrooms very close to bed, they stand up and start walking to the washroom, and the next thing is they hit onto the commode or fall onto the floor of the washroom and injure themselves as they were passing urine, because again, vagal activation comes through the while the urination itself is taking place. So micturition syncope is absolutely a different thing, but all these trigger mechanisms can come into play and can make the symptoms worsen. So non-pharmacological measures do include head up, and that's very important to teach to the patients.
So, here is a question from Dr. Pandey, and he says, ABPM is a class 1 recommendation for orthostatic hypotension evaluation. So what is your comment on advocating ABPM in all patients with hypertension, especially the elderly?
You want me to answer, Dr. Mahajan?
Dr. Mahajan, let Dr. Mahajan take a crack.
Yes. The most important thing is that elderly patients with a hypertension with the symptoms of syncope, always one should go for ABPM, because managing the hypertension in elderly is very, very challenging thing. And the most important thing, if it is also added with this symptom of syncope, then it is very challenging, because most of the drugs for the treatment of hypertension itself causes vasodilation and this increase in the symptoms. So the all patients, elderly patients particularly with the history of orthostatic hypotension or history of syncope, should go for ABPM, and ABPM will tell us what is the heart rate also and what is the blood pressure and how it is there. So it will diagnose all events which are happening in that particular patient over 24 hours.
So Dr. Mahajan, I have a question to you. I use a lot of ABPM. The only two things I have is a Philips system and a Meditech system. Do you use anything simpler which is less cumbersome than Philips or Meditech?
So there is one another new thing which is coming, that is a home blood pressure monitoring. Yes. So most of the time we have to tell the patient or patient's attendant to monitor the blood pressure at home, and if the patient is monitoring the blood pressure at home and coming with the measurements and telling us at the time of this particular symptom patient had this particular blood pressure, then also one can diagnose this particular condition.
No, my question was a little different. I mean, we all are actually strong advocates of ABPM. I said the two systems which I want to learn from you. Do you have a simpler system than Meditech or ABPM? Because I still find both of these cumbersome. Actually, I'm pretty sure that the patients don't sleep well with that at night. Even if you make it 30 minutes at night, 30 minutes reading a night. So
I think sometimes I am not aware of that thing, but that is going to come. That is Apple watches are now training to take a blood pressure, and then I don't know, but that thing might come within some time, because last year in ACC they had shown that Apple Watch is going to diagnose the arrhythmias. So same thing will happen if they are coming with the blood pressure monitoring software.
Yeah, I think we are probably reasonably far away from that because of multiple reasons. But Professor Sharma, there is in the same line the question: how frequently you should be repeating ABPM in high-risk patients?
I completely agree. ABPM is such a cumbersome thing to do. I tried it on my mother, and then I realized what I'm subjecting her to. So it's really some cumbersome thing to do. Maybe ABPM is something that you would do maybe once if you don't know what to deal with. I mean, if you have a symptomatic OH, then of course, Dr. Mahajan, what he was saying, I think I completely agree. You'll probably have to do it. But I think Dr. Mohan, your question was that how cumbersome it is. I mean, do you have a less cumbersome system available? I don't think we have. So maybe you can set it like 45 minutes rather than 15 minutes, maybe have less inflations or something like that. But then that doesn't probably serve a purpose. So I think but that's a problem. Maybe once a symptom, and then if you want to diagnose something new. But if an office recording can confirm it, I don't think you need an ABPM. If you can confirm an orthostatic episode in your clinic or fall of blood pressure on change of posture, probably it may not be needed. But if the patient is having syncope and you don't know whether it's OH or something else, and if you think that the patient comes with different readings of blood pressure, so if you have hypertension with suspected OH, maybe it's a good idea. Unconfirmed OH, that is. But if you have a confirmed OH, maybe I'll not repeat it.
Okay, that's good. We have a question by Dr. Jain, and he said, do we really need to treat asymptomatic patients with orthostatic hypotension? asymptomatic orthostatic hypotension.
So asymptomatic orthostatic hypotension, you need to be cautious. That's all. At least primum non nocere. Don't do a harm. I mean, be very cautious not to use drugs that can actually make him symptomatic from a asymptomatic orthostatic hypotension. So
yes, I would agree with you. At the same time, I may be a little less stringent with salt restriction, with fluid restriction, and of course,
but not the drugs.
Yeah, not the drugs. I would agree. I don't have really, the drugs in any case are not a class 1 indication anywhere. So, and Dr. Mahajan, any different viewpoint on that?
No, I also agree with that. The most important thing is that if there is a asymptomatic orthostatic hypotension, we have to be very, very cautious in those particular patients to prescribe antihypertensives. So they should not exaggerate the symptoms, and they should be given below knee stockings and normal salt intake and avoid diuretics.
So here is the last question. I hope we are on time and we are able to close it. It says, is from Dr. Gupta. It says, place of thiazide diuretic in era of ARBs.
I think Dr. Mohan, you should be answering that, or
so one thing is certain. Diuretics are here to stay forever as a management of hypertension. And the reason is very simple. What diuretics do, ARBs don't do, ACE inhibitor don't do, beta blockers don't do. We have a simple issue that hypertension can be what you call volume dependent. There is intravascular, occult intravascular volume expansion, more so in elderly, more so in diabetic, more so in CKD patients, more so in obese individuals. And then there are another host of individuals who have more volume dependent hypertension. And these are the individuals where thiazides will be required. Whether it is a question of thiazide or thiazide-like diuretics, I will leave it to you. Although the recent guidelines haven't tried to separate them, most of us have moved to long-acting thiazide-like diuretics, which is indapamide and of course clothalidone. Having said that, we also realize the fact that there is an issue of more hyponatremia, and of course at least with these two long-acting drugs, and of course little more hypokalemia because the compensating mechanism take longer to work. But the diuretics actually are something which, if you don't call them diuretic and you call them natriuretic in the right dose, probably they are the wonderful antihypertensive drug. You start giving them in diuretic doses, then they are a problem. You would see many people where, of course, ARBs don't work. You add a diuretic, they work. And of course, sometimes you just prime the renin-angiotensin system so that with diuretics, so that ARBs can work better actually. So multiple reasons. I think we need to keep in mind that regardless of what many of us keep thinking because of so-called dysmetabolism, which because of new onset diabetes, hyperuricemia, hypokalemia, sometimes hyponatremia, and issues with regard to calcium, the fact remains that thiazides are not going to go away anywhere in the management of diabetes for a long, long time to come because of great advantage as natriuretic agents. The sodium plays a big role in actually maintaining the endothelial function dependent, vascular smooth muscle function dependent on sodium. And sodium poisoning actually in hypertension is an important issue in pathogenesis. So you got to get out some sodium to help these patients. But those are my random thoughts on thiazides in hypertension. And I think we would pass on the baton to our colleagues, Prashant and of course, Dr. Nayak.
Thank you so much, sir. On behalf of Intas Pharmaceuticals, myself, Mudit Prashant, General Manager Marketing, extends vote of thanks to our eminent course director, Dr. Professor J.C. Mohan. Sir, with your able guidance only, we could go through this journey of 7 successful webinars in Practice Pulse in Hypertension. I would also like to thank our esteemed faculty, Dr. Kamal Sharma and Dr. Ajay Mahajan for their valued presence and for a very interesting and informative discussion on postural hypertension, orthostatic hypertension. I would also like to thank the backend team for their support, because of which we could do this seamless transmission. And there are over, sir, 900 plus delegates who have joined us today. So I would like to thank each of the delegates for their valued presence. I will request for the support for Silly and Allmark, and I'm happy to inform that 13th February, we will be having the 8th edition of Practice Pulse Hypertension. So, sir, I would request everyone to please join again. Thank you so much. I would like to thank each one of you once again.
Thank you. Thank you very much.
Thank you, sir.
Thank you.
Thank you.
All right.
Bye-bye, Dr.
Thank you
Mark.
much.